Bismillahirrahmanirrahim. What are the manifestations of damage to the basal ganglion, substantia nigra? These are Parkinsonism, and the other condition is chorea. Now we'll start to discuss the Parkinsonism. Or Parkinson's disease. Also known as paralysis, agitans. Now, Parkinson's disease, it results from damage to direct pathway. Damage to the basal ganglion. Or damage to the nigrostriatal pathway. Lesions of these result in a condition called Parkinsonism. Now, what is function of the basal ganglion? Basal ganglion initiate movements. In other words, it kickstart the movement. Just you kickstart a bike. So the movements is started with the help of basal ganglion. Damage to the basal ganglion do not cause paralysis. There is difficulty in starting the movement in case of basal ganglion damage. Now, the movements with the result will be very restricted. Or sluggish movement. First of all, cannot start the movement, and when the movement starts, it is very sluggish, and there is no paralysis in case of damage to the basal ganglion. Now, what are some of the important features of basal ganglia? Some of the major features of Parkinsonism. Number one, is rigidity. Number two, loss of associated automatic movements. Number three, tremors. And number four, hypokinesia. These are some of the major features of Parkinsonism or Parkinson's disease. Now, rigidity. First of all, what is muscle tone? Normally, all the body muscles, they are in a state of slight contraction. That is known as the muscle tone. And the tone is completely lost when death occurs, and the whole body becomes flaccid. But in living body, still if somebody is not moving, the muscles are in the state of slight contraction. It is called the muscle tone. Now, what is the path which control muscle tone? From the motor cortex of cerebral hemisphere, cortico-reticular fibers arise. These cortico-reticular fibers make connection with reticular formation of brainstem. Reticular formation of the brainstem. And the reticular formation of the brainstem is connected with spinal cord. And in this way, it will control the muscle tone. This is the path from the motor cortex. Cortico-reticular fibers originate, which enter the brainstem and connect with the reticular formation of the brainstem. And from the brainstem, fibers arise to enter the spinal cord. In this way, the muscle tone is maintained. Now, normally, Normally, the cortico-reticular fibers inhibit the reticular formation. The cortico-reticular fibers arising from the motor cortex, normally it inhibits the reticular formation. So when there is a lesion of the basal ganglia, substantia nigra, etc., the cortico-reticular fibers, in case of a lesion, the cortico-reticular fibers do not inhibit the reticular formation. You know, in Parkinsonism, the motor cortex is inhibited. When it is inhibited, then the cortico-reticular fibers will be unable to inhibit the reticular formation. Therefore, reticular formation will overfire. The reticular formation will not be under the influence of cortico-reticular fibers. So when the cortico-reticular fibers, they are inhibited, the reticular formation will not interfere, will not be under the influence of the cortico-reticular fibers. Therefore, the reticular formation will overfire and the muscle tone will be increased. This will result in rigidity. Muscle tone will be increased. Both the antagonist and agonist muscles will be in the state of contraction because muscle tone is increased. For example, both flexors and extensors will be in the state of contraction. Both abductors and adductors will be in the state of contraction. The flexor extensors of the axial skeleton, that is vertebral column, will also be in the state of contraction. This will make the body rigid. This result in lead pipe rigidity. This is how the body of a patient suffering from Parkinsonism will become rigid, because both the flexor extensor will be in the contracted state, abductor and adductor in the contracted state, etc. So the body will become very rigid. Next feature is the loss of associated automatic movements. loss of automatic associated movements of the body. You know, during walking, our arms move automatically. And during yawning, we stretch our limbs. These are associated movements which occur automatically, normally. But in case of Parkinsonism, these movements associated with walking, etc., like swinging of the upper limb during walking, and second, the stretching of the limbs when somebody yawns will be lost. Next important feature is tremors. These tremors occur during rest also. This is why known as the resting tremors. In Parkinsonism, even if the patient is sitting or lying on the bed, still there will be tremors. These are called resting tremors. If you compare it with the lesion of the cerebellum, in case of cerebellum also there will be tremors, lesion of cerebellum. But in case of cerebellar lesions, the tremors only appear when the patient performs some motor activity. This is called action tremors in case of cerebellum. For example, if the patient is taking a glass of water, tremors will start. When he is at rest, doing no any movement, the tremors will disappear. So in the cerebellar region, the actions will be present only during performing some motor activity. When the patient is at rest, the tremors disappear. To compare it with the lesion of the basal ganglia, substantia nigra, etc., here there will be resting tremors. The tremors will be present even when the patient is at rest. These tremors occur 4 tremors per second. At a rate of 4 tremors per second, these appear. These are present even during rest, performing no any motor activity. However, tremors disappear in case of Parkinsonism during sleep. The tremors first start upper limb. Then gradually it spread to the rest of the body. And the tremors of the fingers is also known as the pill rolling tremors, like this. Now these tremors, which are even present during rest, there is a circuit known as the reverberating circuit. Reverberating circuit. It maintains a specific tone. Specific muscle tone of agonist and antagonist muscles, flexor muscles, then extensor muscles, abductor muscle, adductor muscle. So during these movements, this reverberating circuit, it maintains the specific muscle tone. It acts like an amplifier. Now, you know, we have cholinergic and dopaminergic activity. Cholinergic activity and dopaminergic activity. Normally, there is a balance between these two activities. There is a balance between dopaminergic and cholinergic activities. So in case of lesion, there is disbalance. The dopaminergic activity will disappear and the cholinergic activity will overfire. Will be lost. The dopaminergic activity will be lost. With the result, the cholinergic activity will overfire. The dopaminergic activity because of lesion will be lost. With the result, the cholinergic activity will overpower. Therefore, reverberating circuit will become fast. This will result in tremors, that there will be rapid alternate movements, for example, flexion, extension, abduction, adduction, both will occur. For example, if the patient wants to flex, there will be overflexion. To correct it, the patient will try to extend, with the result there will be overextension, And this alternate flexion, extension, abduction, adduction, etc., rapid action of both antagonist and agonist muscle will result in tremors. This is the reason for the tremors. Now, normally, when you stimulate a neuron, now in this diagram you can see I have shown 3 neurons making synapses with each other. So when the stimulus is applied, this first neuron, it will stimulate the second neuron. The second neuron will stimulate the third neuron, and so on. This is the normal process when you apply a stimulus. Each neuron will stimulate the next neuron. But in abnormal condition, for example, in this Parkinsonism, when you apply stimulus to neurons, the neurons will be stimulated. So when stimulus is applied, in this case, the Parkinsonism, this neuron will stimulate the next neuron, and then the next neuron. But in this case, the neuron will stimulate the previous neuron also, re-stimulate the previous neuron. Re-stimulation of previous neuron, the neuron before it. It is also re-stimulation. So because of this stimulation and then re-stimulating, the neuron in advance will re-stimulate the previous neuron. So the muscles will contract rapidly, alternatively, without control. This will result in the tremors, which are resting tremors present only during rest. So this first diagram shows the normal process of stimulation of neuron, chain of neurons when stimulus is applied. And here in this Parkinsonism, why the tremors appear? It is because of this, that when the neuron is stimulated, then the neuron which is stimulated, it will re-stimulate the previous neuron again. This will result in the tremors. So this is the reason for the tremors. So we talk about the rigidity, then we talk about the loss of associated movements, then we talk about the tremors. Now number 4, hypokinesia. Next, number 4 is hypokinesia. Reduced movement, it means reduced movements. I told you there is no paralysis when there is a damage or lesion to the basal ganglion. Still there are movements, but the movements are depressed, reduced movements. So the patient movement will be very slow, sluggish movement. And the direct pathway results from this from Parkinsonism, and the indirect pathway is secondary involved. So because both direct and indirect pathways are involved, because both direct and later on indirect pathways are involved in Parkinsonism. Therefore, the dopaminergic activity will be lost. Therefore, dopaminergic activity will be lost, and the cholinergic activity will become more active, and it will overfire the motor cortex, reducing to depression of the motor cortex. When the motor cortex is depressed, so the movements become reduced. This is hypokinesia. Now, what are the other signs and symptoms apart from rigidity, loss of associated movements, tremors, and hypokinesia? What will be the other sinus symptoms in this case. Signs and symptoms of Parkinsonism. Apart from the rigidity, loss of associated movements, tremors, and hypokinesia. Number one, no facial expressions. The face will be expressionless, and the face will give serpentine looks, that is wax-like appearance of face. No face expression, for example, this is expression of the happiness. This is facial expression. Of sadness, anger. No facial expression. The face will be expressionless. There will be no blinking for a patient will not blink for a longer time. He will blink, but blinking will be delayed. So for a longer time, for a long time, he will not be able to blink. Posture will be stoop. That is, the head and rest of the body will bend forward and downwards. While standing or walking, his body will be bent downwards. Stoop posture of the patient. There will be difficulty in initiating the movements. Difficulty in initiation of start of movement. As I told you, basal ganglia initiate the movement, kick start the movement. So when there is damage in case of this Parkinsonism, patient will feel difficulty to initiate the movement. Therefore, the other person will be required to push the patient to start movement. And the patient will walk slowly and with small steps. And with small steps. So these are the other signs and symptoms apart from rigidity. Then tremors, loss of associated movements, hypokinesia. In case of Parkinsonism or Parkinson's disease. Now I told you that normally we swing our arms automatically during walking. So how the Parkinson's patient, he will walk. The patient will walk with moving his arms, or in case of Parkinsonism, there will be loss of associated movements. Patient will move slowly with small steps. And he will not swing his arms. This will be the stoop posture of the patient suffering from Parkinsonism. You can see his body is bent forwards and downwards, and he will walk with small steps, and the limbs will not move during walking. So these are other signs and symptoms of Parkinsonism. Apart from rigidity, resting tremors, hypokinesia, and loss of associated movements. Now, what are the types of Parkinsonism? Number one, damage associated. Damage associated Parkinsonism. Then MPTP associated Parkinsonism. And number three, drug-induced Parkinsonism. These are some of the types of Parkinsonism. So when there is damage to the direct pathway, the direct pathway is damaged, and then secondarily it is followed by damage to the indirect pathway. Then there is damage to the substantia nigra and nigrostriatal fibers. Are damage to nigrostriatal fibers, nerve fibers. This will result in